Hi, I'm Linda. I'm a JR in Addiction Department. I welcome every one of you to the today's didactic topic discussion, which is substance use in women. This is part one. Part two will cover more on approach to treatment as well as challenges in it, approach to substance abuse in women. Outline of my presentation will be epidemiology, social issues, demographic and clinical characteristics, differences in biological response, psychiatric comorbidities, medical consequences, cause of illness, as well as treatment issues. A brief outline on the global data of substance use in women. That is, in US, 6.8% of females report current illicit drug abuse in 2010, and in Germany, high rates of women using hardcore substances. And in Europe also, there is no gender difference between teenage girls and boys in using substance. In UK, there is girls using substance as well as other drugs is more into that is growing more in the recent past. In Russia, females use more substance compared to males. There is 10 times increase in addiction among women. In Afghanistan also, there is increase in use of opiates, pharmaceuticals among women. As well as in Iran, increased use of substance use. China also. And in Australia, there is female rates of injecting substance use exceed compared to males exceed around 1.7% versus 1% in males. All these data suggest the higher rates of substance use in women globally. If we take the data in 1950s, 1980s, substance use in males will be more. But in the recent data clearly shows growing rates of substance use in women, and there is the ratio is changing now, more use in females compared to males. That is very evident from the data. A study done in the substance use survey done in 14 cities showed that substance use in cities among women, most of them had early onset of substance use. They are well educated, employed, and they are single. Substance used were mostly opioids, alcohol, cannabis, and minor tranquilizers. Why I was mentioning this is in compared to rural areas where the substance use is more in middle-aged people, married, less educated, and unemployed. 40% percentage of women used intravenous drug use like opioids, heroin, intravenous drug use, and they also engaged in sex as well as drug selling. Among 2% of women who used substance, that is alcohol, and 11% used tobacco, 15% drank alcohol daily, and 84% at least once in a week or less than once a week. And among the people, that is women who used tobacco, most of them used smokeless form of tobacco. And 1/4 of smokers report that they smoked 10 or more cigarettes or bidis. But a decrease in the use of substance with increase in level of education has also been noted in the National Family Household Survey. What are the causes for the initiation if we see? Mostly it is childhood difficulty, peer influence, partner influence and stress. And the consequences if we see, it will affect the health, it will lead to more violence, inability to take responsibilities in family, work, and 25% had lifetime history and 24% had been injecting in the previous month in a study, that is survey. And majority of in a study, it has shown 87.2% were first time treatment seekers. That is, and physical complications are more in females. That clearly says the stigma associated with substance use in females, and many of them don't seek treatment easily or voluntarily because of the stigma associated with it. This Genesis study clearly shows that 1/3 of women use hazardous drinking, 1/3 had alcohol or using husbands, and 1/10 of them drank exclusively. Prescription drug use is also becoming more among females. Let us see what are the interacting factors for drug abuse among women. That is, first we will see the predisposing factors, that is the genetic vulnerability as well as the personality factors, especially emotionally unstable personalities, modeling by uh, either parents or spouses or sexual partners, peer influence, and ongoing stresses or emotional problems, role transitions, and lifestyle changes, as well as the drug availability, especially in cities. All of these, as well as the lack of awareness of harm caused by these drugs, all of these factors will contribute to the use of drugs. After initiation, the stigma associated with it, the worries about social isolation, the disadvantage, ignorance about the treatment facilities available, and lack of gender sensitive services, even if they seek treatment, all of these contribute to further use of the substance. That is, it is a two-way arm, like one increasing the other. So ultimately, the use of substance will increase gradually. These are the social issues associated with substance use in women. That is greater stigma among women. We speak more about morality in women, and we see them as they are highly as people who are very much promiscuous, very much have promiscuous sexual behaviors, and substance use more likely to affect family life, especially in Indian culture, where women play a significant role in family. It leads to high rates of familial disruption. And if we see the data, compared to substance using men, substance using women have higher rates of divorce, separation, etc. Sex and substance. If we see women using substance, there is earlier initiation into sex. Maybe coerced. Most of them are coerced as per data. They are more likely to face sexual abuse, either premarital or extramarital. Exchange to sex for money, either voluntarily or under coercion. More sexual partners than non-users. 60% has positive feelings about sex and substance use. There is higher rates of violence and substance use in females. Higher level of violence, both physical as well as sexual, in substance using women compared to men. One in two women substance users report violence towards spouses, partners. A significant number of substance using women report violence towards a family, not only family members, as well as with outsiders. One third report violence towards their own children, which will significantly affect the growth and development of children as well as their future. Moving on to the demographic details as well as clinical characteristics of substance using women, women with substance use problems are more likely to involve in because of their use, family members will be affected significantly. Either it could be spouses or children who were it in the family. All of the family members will suffer because of that. And as we discussed earlier, more rates of divorce, more rates of separation, which will again affect the children. Most of the women using substance, they attribute their drinking behavior or using substance to a traumatic event or stressor. That's what data says. Which, in contrast to the males, in males, the reason for using substance more is the positive effect in mood which they get out of substance, compared to females, which is the stressor. More likely to abuse prescription medicines and procure drugs legally through physicians. That is, women, they can easily procure drugs legally through physicians. That's what data says, compared to males. Some of the differences in biological response. Women become intoxicated after drinking even smaller quantities of alcohol compared to men. The reason being less total body water compared to men, as fat contributes most of the body in women, lower concentrations of gastric aldehyde dehydrogenase, differences in organization of neurosteroids that also contribute to differing responses to substance use in women. That is especially in alcohol. Coming to nicotine, typically women smoke lesser, like smoking cigarettes with lesser nicotine content. That is, they smoke few cigarettes per day. They doesn't inhale it deeply. There will be they inhale less deeply compared to men. They report positive mood to a greater extent after nicotine smoking, and a greater decline in mood during periods of abstinence compared to men. Women using nicotine in the luteal phase of their menstrual cycle have greater potential to develop salience because of the effect of progesterone. That's what data says. Women initiate cocaine use sooner, take less time to become addicted to cocaine, and report less euphoria and dysphoria. Progesterone noted to attenuate the subjective response to smoke to cocaine, whereas estrogen will enhance the response to stimulants. That is, in follicular phase, if they take, there will be enhanced response. They have higher cardiovascular responses compared to men, less likely than men to exhibit abnormalities of blood flow in their brain's frontal lobes. Some of the cellular and molecular mechanisms involved. This will be common to both men and women. That's why I am discussing it. But there is no specific literature on cellular and molecular mechanisms and neuroimaging for substance use in women. Aldehyde genetic polymorphisms, as we all know, alcohol dehydrogenase 1B and aldehyde dehydrogenase 2 gene polymorphisms, which are very much associated with alcohol dependence. Genetic polymorphisms of opioid receptor, that is mu1, is associated with alcohol as well as heroin addiction. And neuroimaging abnormalities like corpus callosal abnormalities, gray matter volume abnormalities, which are due to delayed myelination, that will affect the attention span of the person. Motivation will be poor. There will be impaired judgment as well as poor learning. Coming on to event-related potential, there is decreased amplitude of P300 component, which is associated with impulsive risk-taking behaviors, early experimentation with alcohol and other substances, increased reinforcement from alcohol, reducing subjective appreciation of level of intoxication. All these contribute to the early experimentation as well as binging pattern of drinking. There is some sex difference in stress reactivity as well as relapse to substance abuse. There is attenuated neuroendocrine stress response in women with substance dependence on exposure to stress as well as drug use. There is enhanced vulnerability to relapse in response to negative cues. There is high rates of psychiatric comorbidity. Women with alcohol dependence have higher rates of certain co-occurring psychiatric disorders such as major depression, panic disorder, social phobia, and higher rates of suicide have been reported. Following treatment for alcohol dependence, depression seems to be associated with more relapse in women. There is significant association between depression and smoking in women especially. In opiate and cocaine abusers, there is higher percentage of affective and anxiety disorders in women. In opiate users, latent psychiatric comorbidity was more than twice as common in women. As we discussed, there is high incidence of violence, victimization in treatment seeking. Women substance users have high lifetime prevalence of PTSD. Temporal relationship has been noticed with psychiatric comorbidities preceding the onset of substance use in women. Let us see the medical consequences. High rates of liver problems, hypertension, anemia, gastrointestinal disorders noted in substance using women compared to men. Higher risk for infertility, vaginal infections, repeated miscarriages, and premature delivery. Despite lower levels of alcohol intake and shorter periods of drinking, women suffer more severe medical consequences. Postmenopausal women who drink moderate to heavy amounts of alcohol have higher rates of breast cancer. Women using intravenous drugs are at higher risk than men for acquiring HIV. This is more likely that they are more likely than men to inject drugs, use drugs with many partners. They share the things, for example, needles or other things associated with intravenous drug use, exchange sex for money or drugs, and have difficulty in negotiating condom use with their sex partners. Some of the challenges are most of the women using substance who seek medical attention, they have higher rates of psychiatric comorbidities, higher risk for self-harm attempts, suicides. They have lower awareness of their own risk. They share. They are not very much interested in sharing their HIV status. They doesn't voluntarily come to check for their HIV status or other sexually transmitted diseases. And in India, because of cultural or constraints, they the greater than 40% seek permission to consult a doctor when they have really problems with substance use. Telescoping effect is seen in substance use, especially in women. That is, what is it? It is an accelerated progression from initiation of substance use to onset of dependence, as well as first admission to treatment. This is especially seen in women using opioids, cannabis, and alcohol. Women present with severe clinical profile in all aspects, medically, behavioral issues, psychological issues, as well as social problems than men, despite using less of the substance as well as using it for a very short period of time. Challenges in treatment. Women seek treatment for substance abuse less often than men, probably due to the stigma associated with or due to the cultural constraints or familial issues. There is barriers which barriers for treatment include pregnancy, lack of services for pregnant women who are using substance, fear of losing custody when the baby is born because of the stigma associated with substance use in women, or fear of prosecution, fear for sexual harassment. Few programs provide on-site childcare as well as provide assistance with making childcare arrangements. That shows good success of treatment when we data shows when we take care of the day-to-day activities as well as the responsibilities of women, especially childcare, family issues. If we give importance to that and make arrangements for that, response to treatment as well as period of abstinence will be more, especially in women. These are the things which we should particularly focus in treating women with substance use. As we discussed, the problems in all aspects are more compared to men in women using substance. If we take in health related, family issues, biological issues, if we take in all aspects, the problem is more in women using substance when we compare to men. Findings regarding treatment retention and completion are mixed, and treatment dropouts were more likely to be in women, especially who are separated from their spouses, who have poor social as well as family support, and fewer years of education. To summarize, substance using women compared to substance using men, if we see, they have higher rates of psychiatric comorbidities, higher rates of sexual abuse, higher rates of violence, higher rates of suicide, and more stigma associated with it, more social support associated with it, and maybe because of their lack of awareness, or even if they become aware, the gender sensitive issues in substance use should be handled when they seek treatment. That is not very commonly practiced as what we see. And lack of awareness regarding sexually transmitted diseases, their voluntariness to test for HIV or other to reveal their HIV status, all these things come as challenges in treating them, as well as their day-to-day responsibilities in family, childcare. All of these things come as challenges in treating. So while treating substance use in women, we should think very broad. A multidisciplinary approach is very much needed. Approach to treatment as well as challenges as well in it, and the treatment for all types of substance use will be discussed in the second part of substance use module, which will be next week. Thank you. Now it is open for clarification as well as discussion.
Thank you, Linda. I think about 20 years ago, when we were looking at data about women coming to a treatment center, about in the prior 15 years, we had about 75 women. Now, almost every year, we get 75 to 100 women seeking treatment, either in the outpatient or the inpatient. As Prabhat mentioned, for the last 3 to 4 months, we've actually had a separate inpatient facility to treat women. So this is a kind of growing problem. Earlier, we talked of women only as victims of male substance use, male alcohol or drug use. Now we see that women have both the problems. They still continue to be victims when male family members have substance use problems, but in addition, they themselves also have started to develop a whole range of problems. So I'd like to open this up for discussion. We can start talking about maybe, in any of your practices, have you all seen changes in the number of women seeking treatment, in the profile of the women seeking treatment? With nicotine, as Linda pointed out, smokeless tobacco is very common in India. And it's actually very surprising that 20% of women in India use tobacco, of whom 18% use smokeless tobacco and 2% smoke. The problem with smokeless tobacco is that it's so deeply accultured, and that makes it very difficult for people to actually come and seek treatment. And when you look at the reasons for using smokeless tobacco, very often it's to assuage hunger, it's to postpone eating, it's to get rid of stress. So then it becomes a very normalized part of people's living, and that creates a huge problem as far as smokeless tobacco is concerned. In fact, I wonder if anybody would like to comment. We are starting to see more smokers among women are also coming for treatment. And just as Kanika and Linda presented, even among smokers, there's a lot of emotional stress and problems which drive the smoking in them. Alcohol is something that we've focused on a great deal of in this session, so I don't think we need to go back to alcohol. Opioids. Now, opioids again, especially starting in the context of their partners using substances. Very often we have seen injecting opioids as well as benzodiazepine injecting occurring. And Linda had a very important point as far as injecting is concerned, that very often when injecting is done by women in a peer group, very often they are the last persons to receive to take the injection. So it usually passes on through a group of users, and the woman is the last to get it, and therefore her vulnerability to HIV, etc., also increases. We're also seeing a huge amount of increase in pharmaceutical opioids. In fact, we've recently had cases of tramadol dependence among women who've come for treatment, and that again poses, of course, sedatives and hypnotics and pharmaceuticals like opioids and particularly tramadol. We've started to see cases emerging. So I think in every drug, there is a definite trend, and certainly with alcohol, we are seeing the gender gap somehow reducing consistently over time. Thank you, ma'am. I think that's a very valuable thing. Linda, do you want to respond to that any further?
Sorry, ma'am, for the.
Okay, so we'll just take that forward. Anybody else in terms of their present, what they see in their clinic? Are there any differences in what you see nowadays?
Medical college, Aurangabad is a question. What is the difference in psychological assessment in female addiction as comorbid psychiatric problems are more? Any specific scales, assessment scales are available which are women specific? It's a very important question. I think most of the scales, as you know, are designed to probably studies are more in case of male. Now, whether the question is, do you have an assessment scale specific to looking at the gender part?
I think, Kanika, let's open that up to you. I mean, first of all, forget about substance use. Are there gender-specific scales for women when you look at?
I think as basically first started
Can you come here? Speakers.
Like I have pointed out in the presentation, and Linda also talked about when it comes to even the question, the substantive assessment of women is more holistic and broader in scope. The most of the tools for a long time we had is basically which have been standardized and developed for male. So their cutoffs and everything are basically for male. Even the pattern of drinking, where do you drink, frequency, everything is more of male-oriented pattern of drinking than female. But I think last 2 decades, at least in West, they have started standardizing, taking on a female sample. Even addiction severity index, there have been few studies which have been done with female samples. There have been 1 or 2 screening tools which have been basically for females. So those have been recent development, but they are not that extensively standardized. So I think there's 1 tool, I don't remember the name, which is screening 4-item screening tool, which is basically also takes into account female pattern of drinking as well as their pregnancy. So which is more of a specific to the female population. So that is it. Yes, they are very few, and but these attempts are now being made to standardize it. And if you go to sites like SAMHSA, which is Substance Abuse Mental Health Services Administration, and NIDA, they are actually working on it. So you can see a lot of manuals which are female specific. So I think SAMHSA has one manual which is just about the treatment assessments of female substance users. So I think it's good for anyone who's interested to actually go through it, where they have basically talk about all the tools and their relevance. I think that's a good starting point. I would say that.
So very few, but one important step is that they have been standardized. The same kind of existing tools have been standardized for women as well, and you might have different cutoffs for women. But more and more, there are attempts to look at gender-related or gender-specific tools, especially for screening. And as you all pointed out, for comorbidities, I think it's a whole set of different comorbidities. I mean, you look more at internalizing symptoms, emotionality, anxiety, depression, environmental cues. But increasingly, research has also suggested, earlier one thought that male substance use was largely genetic and women's was largely environmental. But even that literature has changed with a lot more genetic risk also being played out for women. And in fact, in many cultures, women's substance use starting to mirror male substance use. Even that is kind of occurring as a pattern. So you see a lot of changes in the pattern of substance use among women as the use of substances among women gets more and more acceptability in society.
And I think that's what, right? Because Linda has basically talked about women suffering, traumatic experiences, private experiences. But literature as well as cases, there are many times women are just using for the sake of pleasure, enjoyment, peer influences. So we should be also not always looking in that direction, looking for trauma, looking for adverse life experiences. We should be also taking it a different perspective, which is also possible, similar to the male pattern. And I think in Genesis study, they have pointed out that for many females, especially in the urban cities, that patterns are very common, and where the abuse or dependence on alcohol is more of a pleasure function rather than as the outcome of a trauma and adverse life experience.
So, for example, the younger women we are getting now have more problems on access to a personality. They start their substances very young in peer groups. They have a lot of positive expectancies around substance use. I think those are the kind of gradual trends that have been noticed as far as the progression of substance use among women in society is concerned. But the one important issue is the stigmatization, that generally, and especially in many parts of the country where women are generally vulnerable and responsible for a whole lot of things, but not given autonomy, that substance use can bring on much more problem, much more stigma, much more underground. People still hesitate to bring girls for treatment for substance use. But just yesterday in the OPD, I had a mother and grandmother of a girl come and say, look, we don't want the neighborhood to know that our girl is using substances. I'm sure that's across families, but it's much more with young women.
Thanks, ma'am. Dr. Jillur, I think you logged in from Dhaka. Welcome. I think you logged in late. Just we are discussing about women and substance use in current session. I thought of asking you, in Bangladesh, what is the situation of substance use in women? You can unmute, I think. Mic is mute. Can you unmute Dr. Jillur's mic?
Yes. In Bangladesh, there is increasing problem of drug addiction among the women, especially in the young women and higher socio-economic classes. But the facilities of treatment in Bangladesh is not adequate. Most of the rehabilitation centers have no seat for female drug addicts. In our country, we see that the boyfriend and girlfriend both are addicted. When the boy is addicted, then girl is addicted. This is the problem in our country now.
Okay, I think thanks, Dr. Jillur. I think probably it's similar in our country itself also, in sense we till today, until last year we didn't have a facility. We have just opened 6 months back an exclusive women facility in at our center, and basically we're running it here. And I think again the second point, that spouse or girlfriend has a lot of influence on the substance, boyfriend or male partner has a lot of influence on the use of the female partner is true here also. We are getting definitely more cases. So in the case today presented also similar, where the spouse has alcohol dependence. Thanks. I think.
Is there any difference in the prognostic factors, male and female?
I mean, one thing I can tell you is about 10 years ago, one of your colleagues had done a follow-up. We were just getting very few women at that time. There were about 10 women who were followed up. Not a single one came herself for follow-up. And at the end of the year, 2 of them had died. I think that scenario has substantially changed. And now we realize that it's only when we have an individual tailor-made approach and make a lot of efforts to get women back into the treatment setting that they come back. Otherwise, their family supports if they are not very good, if they're poor. And if the spouse is also using substances, they're likely to drop out of treatment very quickly. So it's very, very important that you have those follow-ups, services in place. Much more critical for women. And as Dr. Zillu was mentioning, when you go out to the community, you actually see much, much younger ages of initiation. I remember in one of the reports, a girl as young as 8 years old who was in a substance using family had already started injecting drug use at the age of 9. Similarly, very young children, girls start smokeless tobacco use very, very young, because there are aunties and grandmothers who also use substance. So, so both modeling, genetic risk, both of them seem to play an influence in how people start substance use. And certainly when you go to the community, there's a much larger problem. Very few people actually come into treatment. Huge treatment gap.
Yes, like when people come, then we can look on what actually helps women to abstain from the thing. When we look into that, we can, because since there are no things what actually works for women, prognostic factors which improves the abstinence.
I think is Renee here still? She's like, okay. So Renee's been doing some work with the women who use substances, and a large part of her effort is just to get them back.
Yeah.
But it has paid off. I think it's improved from absolutely zero to at least knowing what is happening with 50 to 60% of them. And of course, compliance to treatment is a problem. But the biggest problem are practical problems, or what we call the barriers to treatment. Their distance is very high. They're financially dependent. They have to look after their children. So their coming to treatment depends on convenience of their children. So there are a whole lot of these factors that seem to influence how they do well in treatment.
At least if we get one person, one woman who abstained more than 2 years or 5 years, we can work on case study kind of thing. We can learn from that. Yeah, that can be the time to.
We had quite a few.
Basically, what the point we're trying to tell, is that it needs a lot of effort compared to the gender. Each time I go around in the women ward, each person, each patient will have multiple issues which are very difficult, and it's need a whole team to work from emotional level, support system, comorbidity, physical problem. Half time we admit, people we see in our women ward has physically multiple medical problem. BMI age low as 15, 16. Having communicable and non-communicable diseases, severe malnutrition, so and so action to pellagra, and all vitamin nutrition, and cognitive deficits obviously comes with it. It takes a whole lot of time, 2 to 3 weeks, to get the person better. Previous sessions we presented the cases, and in spite of doing so many things, follow-up rate has been not great, and obviously we go to vicious cycle again.
So one of the things I think is very important is to destigmatize and encourage people who have substance use problems to come into treatment as early as possible, so that we all know that early intervention works better than actually leaving it for all these complications to develop. The other thing that of course we didn't cover are the behavioral addictions. We've started to see also behavioral addictions among women. I remember a girl about 7 or 8 years ago who had a mobile telephone addiction. We recently had a lady with a shopping addiction, and she's doing very well actually. She comes a long way. She comes something like 1,000 miles each time for her follow-up. But for the last year, she's been maintaining follow-up, and she's she's reasonably free of her practically completely free of her shopping addiction.
Tezpur group has written that in Tezpur LGV, the most common is chewable tobacco. I think you will agree with this. But again, chewable tobacco seeking treatment, probably, I don't think you must be seeing people seeking treatment. You just find them as concomitant of other diseases. And also, local made alcohol is the next problem in the Assam. That's the point they have. I think, and MGM, Aurangabad's point is that recently, considering the cases that women get intoxicated much faster, do you think the legal limit of alcohol for women should be less? This is the point they're talking about. I think that is pretty valid points. I think.
I mean, I think more and more. I mean, these are issues that we've not even talked about. For example, looking at breath alcohol levels, and again, when you talk of the legal point, you actually see newspaper reports nowadays of accidents which were caused under influence. They make headlines, unfortunately, because of the woman in question, but rather than the fact of actually addressing some of these things. For example, smokeless tobacco. I think just hospital-based interventions do not work for smokeless tobacco. You've got to have community-level interventions. Similarly, for women who don't find it easy to come to hospitals because they need to have treatment services close to them, which they can access with a reasonable amount of confidentiality and some degree of privacy. So these are all things that we need to start looking at to start developing.
I think, Jillu, can you unmute and speak? Can you tell about the amphetamine a little bit more? Is it women you are seeing in amphetamine? I think, can you unmute the mic of?
Yes, now most of the addiction, recently started addiction are by amphetamine. In our country now, the fentanyl taking or heroin taking has decreased in number, and amphetamine is increasing. And most of the girls taking amphetamine, and boys are usually starting with amphetamine. In the country now, it is the greatest problem.
What about inhalants?
What about
Inhalants. Solvents.
inhalants? Yeah, solvents. Some solvents are used by poor people. Solvents are not used by the well of people. The street boys and street girls uses inhalants. Blue.
There's some data from Pakistan on fair amounts of cannabis use among girls. Is that an issue in Bangladesh as well?
So there is some girls who takes gaja, cannabis, but at present, those who are starting the addiction is starting with amphetamine because it is very much recreational and gives them energy. And the students who wants to read more, study more, they are taking this.
Yeah, I think that is probably expected. My own feeling is that it's underground and coming upfront now. Obviously, amphetamine is the most common drug among with Thailand, Burma, and being as you told, being a even at because it's near to border of Bangladesh, and I think in the Indian borders, like we have seen patient from I think Arunachal Pradesh, Yaba. He came with Yaba addiction, and
Yes.
he procure from the. I mean, so it took us some time to understand, and we really he was not able to tell the correct name. So then we later came out that methamphetamine. Thank you. So yeah, I think we are. Any last couple of we have few minutes left. Any comments from here?
I would like to add few things like availability of drugs, which is more, especially government has, especially if you take in Tamil Nadu and all, a lot of shops are there and they easy accessibility. that availability of drugs will lead to early onset of substance use, which I find mainly in Tamil Nadu and all. And the awareness of the complications caused by the substance use is also less, especially with stimulants, amphetamines and all, especially in females, that pregnancy and delivery and other complications associated with stimulants will be more. And next thing what I feel is because of the stigma associated with, even if they feel like stopping it, they are not willing to discuss it with the family members. And even if they discuss, family members will stigmatize it rather than the the person really needs help. And bringing to medical attention will be a last attempt after saying multiple times to the thing, rather than bringing in the initial time period itself. These are the things which I would like to focus, that need of change in the perspective of the substance use in women should be changed in the future.
I think when we talk relations, we have to understand it's like a complex and multi-layered phenomenon that we have been thinking about. And it required us to be really sensitive to multiple domains, including their gender and culture value. Because we have been time and again talking about it is traumatized population, it is stigmatized population. As a health professionals, as a psychiatrist, or anyone working with basically this population, at least we can do is not to re-traumatize them, not to invoke a lot of problems which they're already facing in society. Even if we can start with this basic step, I think we can go a long way when it comes to helping this.
Modeling also plays a vital role, whereas when compared with the, father having addiction and the son, and that is with regard to daughters, it is entirely different. See, like that I have seen after coming here, which one incident that I like to narrate, like two boys when they were talking, and all of a sudden a girl came. These two boys were working and then shared immediately. And this is commonly seen. This is like peer group influence is much more. It's a kind of a modeling kind of process that is happening in female and addiction. That's what I personally have seen with regard to smoke form of whatever that is. I won't say it's even if it is one use. I don't know how they are named. And nowadays, because of globalization and other things, the metros, you can find all this. Maybe smoke form of females are openly coming out and using, probably maybe way back in 10 years back in Bangalore, and here I don't know, that may be very few, and now it is smoke. Maybe health consciousness, that has to be that also need to be one of the factor that has to be. It's not only in terms of when compared with the men and women, it's in terms of what to say, carrying the generations, like during pregnancy and other issues. That is very important.
What you're talking about, a developmental
perspective as such. So that is also going to affect. So in that way, that is a complex, and we have to go along.
Okay. I think some lessons that we've learned today, of course, is that substance use is a growing problem amongst women. How will it change? What are the associated factors? What are the risk factors? Both biological risk factors and the social risk factors, as well as temperamental issues, and how you need a very comprehensive approach to deal with this problem. Certainly, there's a need of more inpatient settings for treatment for women, community level interventions, reduction of stigma, and a comprehensive intervention. I'm sure we'll learn much more about it in the sessions to come.
Okay, I think I'll wrap up the whole session now. Thanks to all of you for joining from different part of country and even neighboring country. We'll come back next time with the second part of assessment and management of women with a substance use problem. As I mentioned, that we are also learning from our inpatient facility and outpatient facility and our follow-up cohort of women substance users. And probably next time we can take some of the discussion we could not take this time. We'll take it next time. Thank you, everybody. Thanks to all. Till next time, bye from our side.